It's okay to record? Yes, yeah. She's speaking her.
Yeah, we'll get going. Thank you so much for being here. My name is Gigi Weiss. I'm the Director of Rehab at RVA Health. So we want to welcome you all in to RVA Health here. I've been part of this organization for 15 years. I'm a physical therapist. For those of you that don't know, RVA Health was founded in 1914 by two civic-minded nurses that wanted to bring community health to bring healthcare to the communities. So over the last over 110 years, almost 110 years, we've evolved into the organization that we are today that offers health, home health, hospice, palliative care. We have a community health and wellness program. We're able to, we have an outpatient rehab downstairs that offers physical therapy, occupational therapy, and speech therapy. So we're an organization that really brings whatever home and whatever community health that you need into your home. So we're very excited to present our newest initiative, which is this Dementia series. We're kind of launching it today. And Danielle Taibbi is going to, occupational therapist, is going to tell you a little bit more about what we're presenting and our series that we have here.
Yeah, hi, how are you? Thank you so much for coming. We're really excited. Gigi and I have done some presentations out in the community. I'm an occupational therapist by trade. I also worked several years in our private department, training private aides, how to work with various types of clients. And I was getting more and more pulled towards this population because you all were speaking out and saying, we just don't have enough information. We don't have resources. We don't know where to go, and we don't know how to start. And for anybody that's being touched by this, either by a loved one or perhaps wondering about your future cognitively, this is a short-term planning and a long-term planning process. So we thought this is an absolutely perfect initiative for RVA Health because we like to be there from the beginning to the end of everybody's life. That's what our goal and our mission is. And I do want to thank Gigi Weiss, who took this idea and said, let's make this a reality. So we're glad to be presenting to you today. And our first presenter is very exciting because when we asked who we should ask, what doctor we should ask to come speak, we got our first choice, which really doesn't happen very often. And Dr. McElroy was somebody that people said was just a compassionate, well-rounded, wonderful, and have her here today.
So I'm going to introduce Dr. Allison McElroy. She specializes in geriatric medicine, practicing in Wilton as a part of the Stanford Health System. Her expertise includes dementia evaluation, management, medication management, palliative and hospice care. She got her medical degrees from State University of New York, Downstate College of Medicine, graduating cum laude with research commendations. She completed her residency and geriatric medicine fellowship at Stony Brook Hospital. In 2008, she joined Synergy Medical Group in Michigan, becoming a primary clinical teaching location for Central Michigan's University. During her tenure there, she provided care in various settings, including office, home, hospice, assisted living, and nursing rehabilitation centers. Returning to the East Coast in 2015.
Nobody's listening.
No, this one is
Her individual approach considers social factors.
yeah, I see that. They killed me. What happened? Mike will fix.
one's cognitive baseline in one or more cognitive functions, and this negatively impacts everyday activities. So the cognitive functions that can be affected in dementia include memory, I think we all understand that, orientation, comprehension, so one's ability to understand what's told to them, instructions, that kind of thing, calculation, language, and judgment. The activities that might be affected in dementia include things like we call the instrumental activities of daily living. So these are higher functioning, higher levels of function, things like taking medicine, driving, paying bills, and as dementia progresses, it can affect more basic activities of daily living, things like dressing and bathing, and so on. Many times, oftentimes in dementia, we see associated mood and behavioral symptoms. And in dementia, importantly to distinguish it from my next term, is that the level of consciousness is not affected. You're alert and conscious during dementia. Delirium is also known as, I've heard it called hospital dementia, but it is an acute confusional state with altered level of consciousness. So you might be hyperactive, you might be very somnolent or lethargic, and it is often related to some medical illness or change in medicine. There has to be a workup to evaluate that. And it's important to understand that there is a relationship between delirium and dementia, such that dementia increases the risk for developing delirium in the hospital or before the hospital. And delirium, when it goes untreated, or if it's a severe case of delirium, you are at higher risk for progression to dementia. So there's a very complex interplay there. I think I skipped something. Okay. Dementia is an umbrella term. This is how I describe it. There are different types of dementias out there. We all know, I think most of us know Alzheimer's, and a lot of times we confuse Alzheimer's and dementia, but Alzheimer's is under the umbrella term of dementia. It is the most common dementia that I see in clinical practice. It affects about it accounts for about 60 to 70% of cases of dementia. It is an age-related dementia. I'm going to focus my talk today on Alzheimer's dementia. But it is important to note the other types of dementias, which account for about 1/3 of dementias. Vascular dementia is a stroke-related dementia or related to hardening of the arteries. Classically, it presents as a cognitive decline after a stroke, but we may see very different variants of that. There's also dementias that happen in the context of Parkinson's disease, and there's something called Lewy body dementia, which is a related dementia. That is a dementia whose features may include things like visual hallucinations, some Parkinson's changes, repeated falls, blacking out or passing out. In frontotemporal dementia, that's been in the news a lot lately. We have some celebrities who have been diagnosed with frontotemporal dementia. This is something that happens in a younger population, tends to be in a younger population, and maybe they're 50s, 60s, and even younger. And there's different variants of this. One is a personality change. There may be disinhibition. There may be a profound, the other variant is a profound language disturbance. There are a lot of times I see overlapped and mixed conditions. So I might see a vascular and an Alzheimer's mixture there, or different types. I also wanted to note that there are, in a very minority of cases, there may be cognitive decline that's related to an underlying medical illness, things like thyroid disease, for example, or severe vitamin deficiencies, or something called normal pressure hydrocephalus, which I'll show you in a minute. So again, the focus of my talk is going to be on Alzheimer's. A lot of the stuff that I talk about, though, is going to be pertinent for other types of dementia. So this is from the Alzheimer's Association. This is a statistics from 2023. Living with Alzheimer's. We know that Alzheimer's is an age-related dementia, and we have what's called a silver tsunami, which is the aging of the baby boomer population. So that mixture is, equates to a lot more cases of Alzheimer's dementia. This is, again, causing a huge burden on families, on, our resources. Everybody's strained really at this point. Financially, it's a huge burden as well. It says, at about age 45, 1 in 5 women will develop Alzheimer's dementia, and about 1 in 10 for men. And I would say it's fewer men because, again, it's an age-related dementia, and women tend to live longer than men. So this is these are the findings on a typical slide of an Alzheimer's brain. You'll see the plaques here. These are composed of amyloid, and then you see in between them, you see the tangles, which are composed of tau. And the predominant theory for a very long time has been that these plaques and tangles are the cause of neuron death in Alzheimer's. And it's important because a lot of these treatments that are coming out right now are targeting the amyloid plaques. But there's a lot more data out there, a lot more studies that are suggesting that perhaps this is a secondary phenomenon and there's something else going on to cause the neuron death. So this is a gross picture of a brain, healthy brain on the right, and this is the area here where that's the medial temporal lobe, where the hippocampus is. That's where the short-term memory is stored. That is what a hippocampus looks at in a normal brain. In Alzheimer's, the disease tends to start in the medial lobe, temporal lobe of the brain, and this is why we often see short-term memory decline in the earlier stages of dementia, of Alzheimer's dementia, excuse me. And I will say that, you know, there are times in the office where I will talk to people about their memory and or the families about the memory, and the families will say that the memory is so great. They can remember details from a long time ago. There couldn't possibly be Alzheimer's dementia. And I will explain to them that the short-term memories are, again, affected first in Alzheimer's. The longer-term memories are stored out here in the cortex, and you have to make an association. You have to make that short-term memory an important memory for it to be taken from the medial temporal lobe and stored in the cortex. So I will explain the anatomy behind that, and you know, so a lot of times long-term memories are preserved. You know, can be preserved for quite some time, you know, well into modern, even later stages of dementia. So again, on the other side, you'll see a severe Alzheimer's dementia brain. And I mean, there's no medial temporal lobe, there's significant atrophy, you know, it has affected the entire brain at this point. So what are the Alzheimer's disease risk factors? As I mentioned, Alzheimer's is an age-related dementia, so age is a very big risk factor. The increase in Alzheimer's really starts to become very significant after the age of 65. By the time somebody is 85 or older, about 1/3 of people have Alzheimer's. So it's pretty staggering. Alzheimer's does affect younger populations, particularly, I mean, especially like the genetic forms of it, but it's very rare. So family history and genetics do play a part. There is a higher risk when one or more first-degree relatives has Alzheimer's. Again, it's not a guarantee, you know, not unless there's a known genetic predisposition. Also, cardiovascular disease is associated, is a risk factor for Alzheimer's disease, especially midlife high blood pressure and cholesterol. So just another reason why, you know, it's really important to be taking care of ourselves in midlife. Race does have a role. African Americans and Latinos are at higher risk of Alzheimer's dementia, and lower education level. That doesn't mean you can't get, you know, if you have a, you know, Harvard degree or anything, that you don't get Alzheimer's, but it does mean, the way I think about it is you have a very high cognitive reserve. You have, you know, you have an ability to compensate for changes in your brain later in life if you have a very good education level and you keep on learning. And, you know, for people without that, you know, when they have a low cognitive reserve, any changes in their brain is going to be very detrimental, and detrimental earlier on. Sorry about that. Okay, so I just wanted to briefly touch about Alzheimer's disease genetics. I wish I had a pointer, I could point, but I don't. So I will say that if you look up at the purple genes up there, these are APP and the presenilin genes. Those are known to cause Alzheimer's disease, but they are extremely rare. They account for about 1% of Alzheimer's cases, or less than 1%. So they're very rare. We really don't see them very often. The genes over here, particularly the ApoE4, those are very common, but they don't guarantee Alzheimer's disease. They just increase your risk. So it's just important to understand that. You can test for these, but I don't, until they have a cure or a targeted therapy, I wouldn't go ahead and do that. So I'm going to start to talk about the early signs of Alzheimer's disease. Frequently there's a memory loss that starts to disrupt daily life. People may forget about important events. They may forget important dates. They may miss outings because of this. They are increasingly reliant on memory aids or family members or friends to tell them what's going on. I do have, I've had some patients come in and, they are using memory. They may be trying to compensate by taking notes, or they are leaving messages for themselves around the house, or trying to do a better job at keeping a calendar. The patient may become more repetitive, may ask questions, may tell the same stories repeatedly. They may have more challenges in planning or solving problems. So things that used to be fairly easy to them are taking a lot longer to do, and they're just struggling with it. So things like following recipes may be more challenging, for example, or troubling, or with managing finances. Patients in early Alzheimer's might have difficulties completing familiar tasks, such as organizing a grocery list or driving to a familiar location. They may get lost. They might be confused with time or place, and they might wind up somewhere and forget how they got there or why they're there. They have trouble understanding visual images or spatial relationships, and that can lead to things like falls. It can lead to trouble with reading, understanding what's written, and of course to driving. There may be some trouble speaking or writing. So a lot of times I'll have somebody come in and the word is on the tip of their tongue, but they can't get it out. And it's becoming more of a problem. Other people are finishing their sentences. They might have trouble joining or following conversations. They might withdraw from conversations altogether. They may, again, repeat themselves or lose their stop, mid-sentence and lose their train of thought. Moving on, they might be misplacing things in strange places and unable to figure out where these things are. So a lot of times they're misplacing their phone or their keys or something else that's important to them. They, persons with early Alzheimer's can have some decreased judgment. So they're making questionable decisions. I just had somebody in yesterday in the office, and she had a cat, and she did not recognize that this cat was deathly ill. And it wasn't, she called the daughter to come and check on the cat, and the cat had to be euthanized. It was really, really sick. They're very susceptible to scams. I've had, and there are so many people willing to take advantage of that. It's very disheartening, but if I have an 85-year-old who has a new boyfriend who's 40, it raises a big red flag for me. And it's happened. There was, I don't know if anybody saw the paper, but like maybe 4 or 5 months ago, there was a Darien resident who was lost $45,000 on a phone scam. But they call, I mean, they're good enough where they can get, people without dementia, but it's just, it's a higher risk. Again, patients with Alzheimer's may start withdrawing from activities and hobbies. There may not be the ability to plan and initiate that kind of thing. And they may have a change in personality and mood. A lot of times I will see personalities that somebody's been with their entire life all of a sudden flare up, or a mood disorder all of a sudden flare up, or they have a new mood disorder, or they start to be suspicious of people, paranoid. These are frequent things that I see in the earlier stages of dementia. So dementia in the primary care setting, these are cognitive impairment and dementia are either not recognized or recognized but not documented and not investigated further in more than half of patients who are seen by their primary care physician. There's a lot of barriers to making a diagnosis of dementia in the primary care setting. We know that they have very little time, and you need time to evaluate cognitive impairment. Typically, my visits are at least 60 to 90 minutes, and that includes cognitive testing. So time is very important. The primary care physician may not feel comfortable making that diagnosis. Again, they have a lot on their plate. There may be concerns about the implication of diagnosis, and even myself, I have those concerns. So until I've done a very thorough investigation, I do not call something dementia. There may be an ambivalence about the value of making a dementia diagnosis. Is it really that important? Some people just think it's part of life, and you just got to deal with it. So there's a lot of barriers there. So what are the benefits of an early specialist evaluation? Number one, making the right diagnosis. Number two, educating the patient, the family about what to expect. Number three, beginning appropriate treatments. Number four, initiating psychosocial support, which is often really, really vital to keeping families, patients in their homes and honoring their wishes. And also engaging them in shared decision-making and planning. So it's really important to have these discussions. I want to make sure that you've chosen somebody to be your healthcare proxy, somebody who you trust and knows your values and preferences, and you need to do that before your cognitive impairment, your dementia progresses. Same thing with a living will or deciding about, what other big things in the future. So I'm going to go over this a little bit more in detail. So how do I make a diagnosis of dementia, mild cognitive impairment? How do I make a diagnosis? Number one, I interview the patient and the family. It's really important that I have, a family member or somebody who knows the patient well to be at the visit. I do, because of the nature of the problem, I need to also interview that person. I need to interview that person and understand, to get a full picture of what's going on. I'm asking them about the specific cognitive symptoms. So is it memory decline? Is it a change in personality? Is it a language disturbance? I'm trying to get to the bottom of what that cognitive symptom is. how did it start? How has it progressed? Has it been rather sudden? Has it been more of a gradual thing? Are there functional impairments associated with the decline? So I go over all of those activities of daily living, the instrumental ones that are a little bit more complicated, and the basic ones, which are, again, the bathing, dressing, toileting, that stuff. I want to go over the personal history. So, have they had a stroke? Have they had brain trauma in the past, head injury in the past, things like that? Are they diabetics? There's a whole host of things that are relevant to making a diagnosis for me. And I also want to know the family medical history. So it is going to, I want to say this week I had a patient who was seeing me for cognitive decline, and she's got, 2 or 3 siblings with dementia. She's got, both her parents with dementia, had dementia. So, family history is important to helping me make the diagnosis. I want to go over social history. Smoking is, again, one of those risk factors that it's not good for your heart. It's definitely not good for your brain either. Alcohol, same story. Alcohol, if you're a chronic alcoholic, it does damage to the brain and it can contribute to cognitive symptoms. I go over their level of education, what their career was like. So I take a pretty extensive social and medical history. Moving on to exam, I do focus on any neurologic conditions, things like focal weakness or numbness. I might look for tremor. I'm doing a auditory evaluation, so I look in their ears. I do a basic test of hearing because hearing loss is associated very strongly with cognitive decline. I do a cognitive test. Typically, I do 2 of them, and as well as a depression screen. And then moving on, I finish my evaluation typically with some blood work. I would like to rule out, a significant medical condition, maybe that has not been picked up in the history. Also ruling out vitamin deficiencies, thyroid disease, and so on. Oftentimes I will prescribe, give an order for an MRI of the brain. This helps me evaluate, rule out maybe a stroke that's gone missed or other anatomic changes in the brain that could explain the cognitive changes. And then there are times where I will refer for a more extensive cognitive and mood evaluation, something that's called neuropsychological evaluation. I would do this if somebody is presenting with cognitive symptoms, but I'm not picking up much on my office testing, or if they're presenting with cognitive symptoms and there is a significant mood or behavioral background. Maybe there's a history of schizophrenia or a history of severe depression, or there's something else going on that I need to really piece out what is going on. That's about a 2 to 3 hour test too. So it's a lot. It is a lot sometimes to make the diagnosis. I mentioned a condition called normal pressure hydrocephalus. You can see it in the picture on the left. This is a condition where the ventricles in the brain, you can see the normal ventricles on, I'm sorry, the left is normal, the right is the abnormal. There's cerebrospinal fluid in these ventricles. Basically, the pathway for this cerebral spinal fluid gets blocked, and the fluid builds up in these ventricles and it compresses the brain tissue, and it can cause cognitive symptoms. typically along with a gait problem, people tend to have what's called a magnetic gait. They tend to fall a lot, and they can have some urinary incontinence as well. So these are one of the potentially reversible conditions that we might pick up during our evaluation for dementia. It's not a common condition, and I will say it's the treatment, there's further evaluation to prove that this is contributing. They typically will try to remove by a lumbar puncture some of the fluid and see if things are getting better, any of your symptoms are getting better. And then they proceed with it's a drain, basically, to drain that fluid, but it stays in your body. So. Okay, so it's important for me. I spend a lot of time in my office visits educating, when I make a diagnosis, and again, whatever that diagnosis may be, mild cognitive impairment, dementia, I am going over the diagnosis pretty thoroughly, and I'm going over prognosis as well. Mild cognitive impairment it does increase your risk for progression to dementia. About 12 to 15% of patients with mild cognitive impairment will progress to dementia per year. With regards to dementias, most of the dementias are progressive, and there's an expectation that there will be further decline in cognition and function over several years. For Alzheimer's, it's typically about 6 to 10 years from the symptom onset to the very late stages of disease. Now, I've seen, shorter progression. I've seen people that are well beyond that time, but that tends to be the average. Over this time, again, along with the cognitive decline, there is functional impairment. And that's where the support, the caregiving is really going to be, have to be stepped up. Earlier on, I mentioned those instrumental activities of daily living, they become impaired. Things like driving, taking one's medicines, which poses a lot of challenges, managing finances, preparing meals. These tend to be affected earlier in the course of the dementia, and people will need assistance with these things. Later in the course of the disease, those basic activities of daily living, the toileting, the bathing, the dressing, feeding oneself, these become affected. Typically feeding is the last of the activities to be affected. Along with, again, the cognitive decline, there are safety concerns. There's a potential for accidents, especially if somebody is living alone. There's been wandering. I know we've seen stories where people wander. I had somebody wander out of a nursing home where they were for rehab in the middle of winter and walked 6 miles home. I don't know how he got there, but wandering happens. People die because of it. There are all sorts of safety hazards that we have to consider. Behaviors tend, again, to prop up during this, and it's important for families to understand. It's not the person that's being difficult, it's their disease process. So management, what do I do as a geriatrician? First of all, in terms of medical treatment, I address factors that may contribute to the cognitive decline. So there are certain medications that might contribute to cognitive decline, and I'm going to get to that in the next slide. Hearing loss, as I mentioned before, is associated with cognitive decline. I really do stress the importance of a thorough evaluation for hearing if I pick that up on my exam. Anxiety and depression, they can also contribute to cognitive decline. They affect basically the input of information. Your concentration is affected, your attention is affected in mood disorders, and that will affect your output. So it's important to address these along with the cognitive decline. So one of the things that I sometimes have fun doing in the office is deprescribing. I particularly focus on the medicines that might have a negative effect on the brain. And a lot of the patients that come to see me are on medicines. They might be on medicines for anxiety, like the wrong medicine for anxiety. They might be on it for sleep. I mean, sleep is like one of those things I wish I had the safe magic bullet, but there really isn't a safe magic bullet. There are bladder medicines. So, I mean, I'm sure many of you have heard of some of these agents. So painkillers can affect cognitive function. Bladder agents, especially the older ones for overactive bladder, can affect cognitive function. Alprazolam and that class of medicines, the benzodiazepines. And the sleep medicines, I put Ambien there. There's also over-the-counter medicines. Anything that is a PM medicine has Benadryl in it, diphenhydramine, which is a anticholinergic. So anticholinergics can cloud your brain, and they have other side effects too, things like constipation, dry mouth. So you might be taking that medicine and not even realize it. So it's important for me to go over over-the-counter prescriptions as well. So moving on into therapies, we have the cognitive enhancers, which maybe some of you are familiar with, things like donepezil, which is Aricept, or rivastigmine, which is Exelon. And then there are the NMDA receptor antagonists. Memantine is the one that we use. These medicines act on the neurotransmitter levels, the acetylcholine for donepezil and the glutamate neurotransmitter in memantine. These medicines have been around for a long time, particularly donepezil. I think back in the day, it was thought that they slowed the disease progression, but that is not the thinking anymore. When I talk to patients in the office about these medicines, I tell them they're cognitive enhancers, that they might provide some symptomatic benefit, but do not change the course of the disease. And the analogy that I give is if you take Tylenol for arthritis, you're not fixing the arthritis. You might alleviate the pain for a short period of time. So if I do prescribe these, I consider it a trial. If somebody comes back or the family comes back and says, they're doing better, they're more alert, maybe they're thinking more clearly, maybe they're talking more, whatever it may be, and they're tolerating the medicine, then I'm okay with continuing these medicines. There might be a little bit of a behavioral benefit, particularly with memantine. Again, I mentioned that behaviors are very common in dementia as it progresses, and we sometimes need medicines to treat it. So memantine and sometimes donepezil can be used in that context, but I don't know that they provide dramatic effects. In terms of side effects, there's tends to be more potential for side effects with Aricept with the acetylcholinesterase inhibitors, mostly gastrointestinal. So nausea, vomiting, weight loss, diarrhea, if I'm going to see a side effect. So a lot of you probably have heard about the monoclonal antibodies that are have recently emerged on the market. The first, these are monoclonal antibodies are targeting the amyloid plaque in Alzheimer's disease. So we had, I showed you that, back several slides ago with the, that this was a very common feature in Alzheimer's disease. To qualify for these medicines, you have to demonstrate the amyloid plaque, either by a special imaging test, like the amyloid PET scan, or by some other biomarker. They do have blood biomarkers, which are still in clinical research, but anyway, the first of the monoclonal antibodies to be sort of approved by the FDA was the aducanumab, and that was back in 2021. And I don't know if you guys remember this, but there was a big kind of like firestorm around this medicine because the advisory committee mostly said, no, it doesn't have an effect. And the FDA went on to approve it sort of anyway. And then a bunch of people, quit the advisory committee. So it was a lot of controversy, and it never really came to fruition. And actually, the Biogen actually pulled it from development a month or two ago. There is a newer monoclonal antibody, Leqembi, that came out last year and was fully approved. And it was based on a study, rather small study, in patients with mild cognitive impairment or mild dementia with proven amyloid pathology. So, proven Alzheimer's, on one of those biomarkers. Now, in the study, they did show that the monoclonal antibodies do a very good job at removing the plaque. The question for a lot of us is does that lead to clinical improvements? And I don't think we've shown that. And it's a tough medicine to take. It's an infusion every 2 weeks. There's something called ARIA, which is like brain imaging abnormalities, swelling of the brain, microhemorrhages, which sometimes can be symptomatic. So there's, it's a very expensive medicine. So there's a lot of downsides to this medicine, and it's been hard to get it up and running. Even Yale does not have Leqembi in, full clinical practice right now. And we certainly don't. So it's one of those things that, I think we need a lot more data to figure out if this medicine is going to be sticking around for a while. There is a newer monoclonal antibody called donanemab, which should be coming out this year. It seems to be, again, it does the same thing as Leqembi, seems to be maybe a little bit safer, a little bit more effective, but I think there's still a lot of data that needs to be pursued. And that seems to, okay, there we go. Okay, so moving on, the other benefit, again, of an early specialist evaluation is getting patients and families hooked up with psychosocial support, and that comes in a variety of forms. I didn't really mention it on here, but a lot of times I am, if there is a skilled need, I am referring to a nursing agency. And that might be for medication management. It might be for physical or occupational therapy. It might be for a variety of reasons, but and that is something temporary covered by Medicare. Patients and families often do benefit from a social worker. A lot of times I can get a social worker through a visiting nurse, and they can also provide a lot of education and support to families. There are social workers called geriatric care managers, which are more private social workers that can do more individualized treatment plans with patients and families. So particularly if I have somebody whose family lives out of town, or if there's a complex situation and I need real hands-on social work, lots of hand-holding. Maybe there's a strange family dynamic, not everybody's agreeing, and we need to bring everybody together. A geriatric care manager can be very helpful. A lot of times I will refer patients to Agency on Aging. There for patients that financially qualify, there's the Connecticut Home Care Program for the elderly, getting them some chronic care services like aids. There's also information that they can get from the Agency on Aging on local senior centers, adult day programs, which can be very helpful. You know, especially I'm thinking about, for spouses or for, children who work during the day, and, the spouse or mom or dad or whoever that may be is at home and really could benefit from some stimulation. They can give information about Meals on Wheels and support groups like the ones that they have here. There's also Alzheimer's Association is a great resource. They have, if anybody isn't already hooked up with them, they have a great caregiving page. They have a 1-800 hotline, for all of your dementia questions. Alzheimer's Association is a great resource.
Danielle? We have an emergency.
I'm sorry, everyone, to interrupt.
I am pretty much close to the end of my talk. So, I just wanted to show you some of the resources. Again, the Alzheimer's Association, look at their website, donate. They're a fantastic group. Also, a lot of times I will recommend a book called The 36-Hour Day. It's everything you want to know about dementia and caregiving, and it's a fabulous book. The other thing I did want to talk about, I've got 2 more slides left, okay, is planning for future care. So I always talk to families about, what they envision for themselves, and I get different stories. I have a lot of patients that, want to stay in their home. They'll do everything they can to stay in their home. I have others that, want the social benefits of an assisted living or something like that, or maybe there's a plan to move in with the kids. But it's important to start talking and thinking about what that plan will be. As I mentioned before, it's super important to designate a surrogate decision maker. I think most of us have one, but there are times where I have somebody that comes in and they're concerned about, they have some cognitive concerns and they don't have an advance directive, they don't have a healthcare proxy or a living will, and I will make that a very important thing to do on the agenda. The other things that it's important to talk about is, again, reducing the risks that are associated with dementia. So hospitalizations are very common in this population, you know, and that can be for a variety of reasons. Maybe they're not, you know, they're falling a lot, they're not using great judgment, maybe they're not taking their medicines and, you know, they needed to be on that blood thinner, or they're taking too much of the blood thinner. There's a lot of things. There's, you know, they're at a high risk for accidents and injuries. I had one patient who thought Clorox was Kool-Aid and drank, you know, a cup of Clorox. You know, guns are, you know, people have guns, and it's important to think about what to do with the gun, how to protect people from that. So there's a lot of things to consider in this group. So I know there's a hot topic of dementia progression, dementia prevention. And, you know, there's not been, I would say whatever is good for your heart is good for your brain, right? It just makes sense. So moderate, vigorous exercise, aerobic exercise for at least 150 minutes per week, a brain supporting diet. So you want to get omega-3 fatty acids from fish. You want to restrict those processed foods, really focus on, you know, fruits, vegetables, whole grains. All of that makes sense. Avoiding smoking, very light consumption of alcohol. You want to keep your brain active, always be learning, always be looking to learn, and you want to be social. A lot of us tend to like to regress into, you know, our, you know, smaller circles, but the people that live the longest and have the healthiest brains are the people that keep extending their social networks. So that's really important. Getting adequate sleep, that is, we cannot be, you know, overstated. And helmets and seatbelts. And I will give you a little story. Last year, I was in Utah with my kids, and they all wanted to go mountain biking. And I went mountain biking with them. And on our way down the mountain, I flipped over my bike, and the last thing I saw was the ground, but the helmet clipped the ground, and I was fine. I was a little bruised up, but I was fine. And it just gave me, you know, I know how important helmets are, but it gave me a much greater sense of importance of the helmet. So, you know, prevention, right? There is not a single supplement out there that has evidence base showing prevention of dementia. I get a lot of questions about that, about ginkgo and a number of other ones, and there's just not the evidence base to support that. That is it. Thank you guys for being such great listeners. You can, there are biomarkers in the blood that you can test for, not covered right now, still considered, you know, it's not covered by Medicare, but you can pay out of pocket for them.
But how reliable are they?
They're pretty decent, you know, reliability. They're getting better. I mean, I personally have not ordered them. If I'm, you know, if I'm going to go a biomarker route, I'd prefer to go the amyloid PET scan. Yeah.
Yes, I think there are
I've never heard that taking naps is bad. During the day, I'm assuming you're talking about, but I mean, taking naps during the day can throw off your sleep at night. So I don't, if it's not affecting your sleep at night, I don't have a problem with some naps during, the day. And I don't think that has a negative effect on Alzheimer's, no. Go ahead.
If I understood correctly, you said there's kind of an association between hearing loss and dementia.
Yes.
So if somebody has impaired hearing and they're not using a hearing aid, would it be helpful to slow the progression by getting and using a hearing aid, or are they just kind of?
So there is a benefit to getting tested and a hearing aid if it's appropriate. Absolutely. I think, is it going to make a tremendous effect on the slowing? I don't know about that, but there's definitely a relationship between the loss. If you're withdrawing because of your hearing, you're not getting information, and that can accelerate things. Yeah.
And if someone's taking a pain medication that they need for pain, that might, what do you do?
Risks and benefits. Everything in my population is risk versus benefits. I have patients that, maybe they've been on the benzodiazepines for a low dose for years, and it's controlling their symptom, their anxiety, or I don't necessarily look to stop it, but I do educate people about it. We have discussions, same thing for pain medicines, it doesn't cloud everybody, but it's just one of those medicines that gives me a little pause when I'm looking at their med list. So we talk about it. And every treatment, every test, everything that I do as a geriatrician especially is, begins with a discussion about the risk of that and the benefits, the potential risks and benefits. Go ahead.
You mentioned that you're in Wilton, so you're familiar with the area around
Yes.
here. Are there any daycare centers, any place where someone with mild impairment can go for a few hours for socialization? There used to be, but.
Yeah, so there are adult day programs, which you may have heard about. There's Elder House in Norwalk, there's one out in Greenwich, River House, there's, I think Waveney's back up and running.
Oh,
No, you don't think so?
I
Okay. Well, so there are adult day programs. I think those are for more impaired, but I think I have some patients that are going to the senior centers, for engagements. I think that's always an option too. What is the name of your program here in Richfield? You guys have Founders Hall, right?
Right, but that's not for someone who's very.
Can I interrupt?
Yeah, go ahead.
The Alzheimer's Association has like social groups who are mildly impaired. So you should go to the Alzheimer's Association website or call them on the phone. They have these things called GAP programs, giving Alzheimer's purpose. And they have like planned activities or a planned outing. My husband's been going for 6 months. We go together. We both right. But it's good.
That's great. Good to know.
Sorry.
Go ahead.
Yeah, I've heard that sleeping on your right side help with reducing the risk of dementia. Do you have a comment on that?
Never heard of that. I don't know. That sounds a little iffy. Kind of like sleeping with a bar of soap under your pillow. Go ahead.
You mentioned something about a depression screening. What does that look like?
So depression is very common, throughout our lives, but especially as we get older. So I do a test that's called the geriatric depression screen. There are different tests out there, and most likely your primary doctor has done something similar to it. But if it's just one of those things that helps me understand if there's a significant depression and if that might be contributing to the symptoms that somebody's presenting with.
More like your questioning.
Yeah, it's a yes or no questionnaire, 15 questions, yeah. Go ahead.
What can you do if the hearing aids don't seem to be enough? Are there different levels of hearing doctors? My mother's going to Costco, and that's, it seems like her hearing aids don't work very well.
So, I would imagine that an audiologist is going to prescribe the hearing aids for, the degree of hearing impairment that you have. You can always get a second opinion about that, but, you don't want, you can't treat that excessively, right? It doesn't, you just need to treat it for the degree of hearing impairment that you have.
There is going to be on April 9th, an exploration of hearing loss and dementia with Leslie Ogilvy, who's a hearing aid specialist. If you're interested, it's on this sheet because this is part of the series. So one just focuses on that very issue. Okay?
That'll be in person and Zoom as well, so you can. Yeah.
Anybody else have questions? Go ahead.
I just had a quick question. I always thought you could not determine whether it was Alzheimer's till after that death, and you had.
That's true.
Right.
That's true.
So is when you're dealing with people and talking about Alzheimer's, is that this is what we believe it is?
Yes, I can say with reasonable certainty based on the history, especially again, if it's a short-term memory and the language and disorientation, and then I use my cognitive tests, which will show me, the cognitive test will tell me what areas of cognition are affected. And I'll see a different area for Alzheimer's versus something like vascular dementia. So I have to look at the big picture, and I can get it with a reasonable certainty, that it's Alzheimer's. Most of the patients that I see, it's an age-related, it's the most common, so it tends to be the more common one that I diagnose, but there are definitely other considerations that I have. Thank you guys for being such great listeners. Thank you.
Sorry, sorry. Anyway, how's everything?
There you go. Well, good to see you. Take care. Good to see you.
I spent all night trying to figure out how to do this. Yeah. So I thought it was doing what Teddy did, I thought it was like done. But it don't do it. So I couldn't figure out how to do. Yeah, like, so I gave up. It's just never it doesn't get this black video. And then this morning it said it was done, but it let me download it. And I spent like an hour and a half on it last night. But then this then MP3 wasn't playing. It's like recording. And I finally got it with where I left. Yeah. So I just let it over to the contract. Hopefully something works for them because I don't have I'm prioritizing my new ones now.
I think sleeping on the left side, by the way, better than the right side.
We allow you to pay like monthly utilities or if you work out like if someone's if someone's in their 80s, 90s, they can start to work out.
she's our ear specialist.
Thank you so much. Danielle? Hey. Hi. Thank you so much for coming. I'm Danielle. The library. Hi, very nice to meet you. Yeah, I was my brother is on and he had a question. Okay. So my parents are in Rochester. Do you know somewhere there that represent a diagnosis? What you can do is that's my expectation. She got has links to services. I don't personally, I don't have a computer. I would think so, but I would also go on that.
The second part was, you said, really, what's, how important is a diagnosis?
So here's the thing, like, so, who are you, yes, my dad.
No, that was my father-in-law. Yeah, he was, I think my father was in the 1 to 3 masking for a long time. He can do daily activities, but like he relies on my mom. My mom is saying that she's taken over. She used to go in
So are you saying oh, is it downloading?
I just pushed, do I stop it
Oh,
now?
yeah, hit stop recording.
Okay, because I thought I had to.
Nope.